Steve, thank you very much for being with us today and for all the comments and for all the reviews on our module on COVID and post-COVID. And before we start with the questions specific to the topic, can you tell us about your professional background, please?
Thank you so much for inviting me. And yes, it's been a pleasure being part of this project on COVID and post-COVID. My background, I've been a general practitioner, family physician for about 33, 34 years now. I've been heavily involved in the respiratory world, both in the UK and more recently with the IPCRG. And I was quite strongly working around in England at the time of the acute COVID coming into the country, and then in setting up post-COVID recovery clinics soon after that, which have subsequently been taken on by colleagues. So I've got quite a COVID interest, I've got quite a respiratory interest, but I am a genuine generalist.
Oh, that's wonderful to hear, because then you'll probably have lots of share with us about these two topics. And just jumping straight ahead to our questions. Based on your experience, what do you think are the current challenges for the diagnosis of COVID-19 in the primary care setting?
I think it often depends on where the setting is. So the first thing is that in primary care, if we have access to good assessment, we can often tell whether somebody is poorly enough to warrant hospitalization or whether we feel we can manage them safely in the community. And that is often linked to respiratory rate, blood pressure, pulse, their general condition, the history, their temperature, and also, if we have it available, which in a lot of parts of the world now we do easily, pulse oximetry. The parameters of those are pretty well described. Determining whether the acute respiratory symptoms are linked to COVID, influenza, another virus, or a bacteria can be more challenging, but actually determining the severity of disease and the need for hospitalization is perhaps less challenging. It's they need to be in hospital no matter what the cause is, or I can manage them safely outside no matter what the cause. Then I'm thinking, do I need an antibiotic, or do I need, if this is a virus, do I just give clinical advice and safety netting to bring them back?
And that's such a good point on differentiating the setting. Because then a next question to follow up on this is there any advice that you could provide to those primary care workers that really don't have much at hand to assess patients and to support them? Is there any advice you have for them?
I think the things on that are, I think, number one, even if you have a pulse oximeter, please remember that the readings often underestimate severity in those of us with darker coloured skin. So that's the first important catch for those with a pulse oximeter. Using a pulse, assessing respiratory rate are good indicators of how well somebody is at that time. A good history often helps, and a careful examination often helps. And again, I think in different environments in the world, when these things are available and when they're not, I think we have really good expert family physicians who are able to make those judgments. And it's a pleasure to have worked with some of them in other countries where they don't have access to easy pulse oximetry and that sort of thing. It's clinical judgment and careful assessment. And I guess that goes on to the next thing is, if we don't have the kit, but we can listen into the chest and we can assess properly, that gives us more of a hint as to whether it's likely to be a bacterial cause or COVID or another virus. COVID and other viruses may be coexisting together, so often we'll get flu at the same time as we have COVID. The bacterial cause is often, in the experience of a lot of clinicians and some evidence, slightly higher temperature, a slightly higher respiratory rate at times, but more importantly, localized signs when you listen into the chest. And those are the people where we'd be much more likely to use an antibiotic.
And so let's say we are on a primary care setting and we have a patient that is eligible to receive antivirals for COVID. Have you had any experiences treating these patients? Do you have any advice, anything to share about antiviral treatments?
Yes, I think the key things about that are, what access have we got to these? Where are they? And for which groups of patients? And I think in many countries that varies. So in some countries, it will be very difficult to get hold of any antivirals in this sort of scenario. In other countries, there will be systems set up so that the patient can get them if they have a positive COVID test and they fulfill certain criteria. I guess one of the things that many people are much more wary of is, in someone who's had effective immunization, are well, may have a confirmed COVID infection and have no past medical history of note, they will often manage very well without further antivirals. In those who are immunosuppressed or have a susceptibility to infection or have other long-term significant lung/heart conditions, there may be much more of a compulsion to push them towards some of the antivirals. And again, it depends on local resources and the systems as to which antivirals to use.
Mm-hmm. And so we have some considerations for assessment of patients with COVID. We have some considerations for the treatment with antivirals. And thankfully, then in the majority of cases, this will mean that our patient has recovered, has been able to recover from COVID. But as we know now, it's not in all cases that they will be immediately feeling well and ready to go back to their day-to-day tasks. And when it comes to post-COVID, primary care is most likely the main source of support with people with persistent respiratory symptoms. And however, though, it's still not easy because this is all new. We are still learning. We don't have guidelines that are ease of access for primary care workers, and this varies among different countries. So from all the issues that primary care workers will have to sort through, what do you think are the main barriers for healthcare providers to provide good care to post-COVID patients?
I think there is plenty we can do for post-COVID patients. And I think one of the first barriers is being absolutely familiar with normal recovery in a fit young person, normal recovery from a more severe acute COVID environment, and those that seem to have ongoing persisting symptoms. Many of us by now will have had COVID at least once, and will know that most of us will get better within sort of 4 to 12, 14 days. And quite a lot of us will be thinking, well, I tested positive and I only had symptoms for a few hours. Phew, that's good news. And let's hope most of us do get that sort of experience, especially with immunizations. What we know about that sort of grouping is they will often recover very quickly. Great, tick, easy. Some of those we know who are admitted to hospital, the ill ones that we've seen, will normally, from the literature, react very much like other forms of pneumonia or pneumonitis. So they'll often have a cough and persistent breathlessness for about 6 to 8 weeks, and will still be feeling a bit tired at about 3 months. That's normal recovery. If they're following that track, even though the symptoms are a little bit persistent, but they're slowly improving, good positive reassurance should make a difference. The other group of people are those where they've had acute illness and they are those that is ongoing or worsening. Think, have they got a secondary infection? Relatively less common in COVID than with other infections, but still a possibility. Or is there something else that's complicating that? And if you're in a primary care setting, again, careful examination, things like pleural effusions, things like empyema are not unreported. People also have spoken about interstitial lung disease with other coronaviruses, but it's about assessing that patient to see if there's another reason why they're getting worse. And remember, many of the COVID variants have been a problem where the person has become more likely to have things like deep vein thrombosis or pulmonary emboli. And so that should be part of our differential. And I guess one point from that is, if the patient is not recovering in the way that you would expect from that normal infection, don't be afraid to investigate. There are other things that can cause this, both cardiac and respiratory that can prolong recovery. That's go on.
And that brings up, I think, what is one of the most difficult aspects of post-COVID treatment and management for me, which is testing. Like it is really hard to know if it's too much or too little. And we have some of a conflicted dual loyalty, because we have the loyalty to the patient, where we would want to do as much as possible to make sure everything is fine. But then we have this loyalty with the public health, where we also need to be mindful of not making excessive use or unnecessary use of health resources. What are your thoughts on this?
I think probably the sensible approach with that is to think, if somebody came to me and said they have a cough for 6 weeks that isn't getting better, then most times I would think about a CT or a chest X-ray after I've examined, to make sure they haven't got something like a carcinoma of the lung. Or there are other problems that you will pick up, but that's one of the key things. Please don't miss out on that sort of thing. So we need to investigate that group of people. When I was doing the post-COVID recovery clinics, I saw quite a lot of people who'd had diarrhea for 6 to 8 weeks. Again, a well-recognized potential symptom of carcinoma that we should evaluate properly. And thankfully, my colleagues were doing that, and I would recommend we do that. If there's a possibility this is a significant other disease, we should be doing the proper tests for that. If we have excluded those other areas, and we don't just do a blanket test, that is selective testing, depending on what those symptoms are, and it fits a good pattern for persistent post-COVID type symptoms, that's where we're actually trying to minimize symptoms, maximize the things that people can do to look after themselves, and maximize their function. And
we would hope that all our investigations would be negative, and that we would, in an ideal situation, it would be just a long-lasting symptoms of a COVID infection, and that's the place where we would like to be, right? Where we can tell our patient, you will recover, you need to be kind to yourself and pace yourself, and just go with them along the way. And as we support our patients, something that has been coming up to the discussion in Canada, in Europe, is involving multidisciplinary teams or interdisciplinary teams to support patients, which would mean also occupational therapists, psychologists, and so on. So what advice do you have for primary care doctors to do a bit of this play of collaborating with others to support post-COVID patients?
I think, number one, if you have a local service and your patient is having trouble, point them in that direction, get them support. If you don't, you might want to go for some of the online things like Your COVID Recovery website, or other websites that actually help patients to look after themselves. I think you brought a lovely phrase. You said, be kind to yourself. And a lot of the people that I saw who were having problems recovering were highly driven individuals. They were either highly driven professionals who, whenever things got hard, worked harder, or they were people who were desperately trying to care for their children and families and were very financially hard up. And the only thing they could do is to keep working hard. And I think we need to accept that, like a fractured leg, where you're in plaster for 2 or 3 months, we need time to recover in that sort of environment. And the more we can encourage our patients to do that, the better. Next important thing, certainly in the UK market, where we are often asked to advise about fitness to work, is I was quite commonly providing a little note saying, this person has had a severe COVID infection and is on part of recovery phase now. Please allow adapted work, phased return, not pushing them into the full work that straight into it, but give them a chance to build back up with a comment, doing this successfully will get them back to work as they were before. And so I think we have a sort of support to help to do that. I think we should try to encourage our patients to be sensible about how much work they do. And physiotherapists will often give a good structured way of increasing the amount of activity they do within the limits of what is sensible and what restricts symptoms. And at times, it can be really hard if you are so frustrated by a condition that you weren't expecting, that you didn't ask for, and you're having to survive, that people will, psychological help is part of the normal areas. Probably another useful thing I was doing when speaking to people in the more severe end of the post-COVID recovery clinic was saying, if you didn't have any mental health type thoughts about this, if you weren't worried about this and for your long-term health and other things, that wouldn't be normal. To have some anxiety about what's going on and to feel a bit low that you can't do what you used to do would be a normal bodily response to a severe infection.
And when it comes to putting ourselves on the shoes of the patient, and when we imagine a patient that is struggling with the symptoms and it's finding it hard to just keep going through life on busy schedules and so on. I think telemedicine, like on my perspective, one of the main advantages it brings for care of these people is convenience. It's just giving them an option of we can also work together on this way. You don't necessarily need to come to my office every time and find the time to do it. How else do you see primary care doctors using telemedicine to manage maybe both COVID and post-COVID, but focusing a bit more on post-COVID and helping patients recover?
I think it's interesting because I think before the pandemic, a lot of primary care clinicians were working much more closely with our patients over the phone. And I was teaching how to do telephone consultations in 1990. And that's because when we were on call at night and someone phoned up out in a farm many miles from the surgery and said, I've got this cough and I wonder whether I need to come in or you to come and see me, I would need to triage that in a sensible way. So for primary care, this is not a new experience for many different family physicians across the globe. And many of us have used telephone consultations for a long period of time. Less of us have used video techniques during that time, but that again has been very useful. And the ability for patients to send pictures of rashes or some of the other things they want to show us about what's going on can be very useful. And remember, quite a lot of patients with COVID had either urticarias or other skin presentations with that. So I think we should be embracing that telephone and video and photography type processes. Obviously, telling them not to send pictures from inappropriate parts of the body that might go astray or anything like that. I think the second thing, along with what have we learnt from the changes with telemedicine, is a lot of our hospital colleagues now are using the telephone. That's great news. Because it saves the patient going 2 hours to be told their blood test was normal. And great that we're getting a lot more common sense with that. Third thing that's really important around this is that many of my patients now have their own pulse oximeter and will be monitoring themselves at home. Some of them will have blood pressure machines as well. And we're starting to move into much more of an era where we are in partnership and sharing decisions and care, rather than us being expected to be the if you like, the person who tells the patient what to do. And so to me, that's a very exciting part, which we need to train the doctors of tomorrow for, and we need to adapt to, so that we continue to provide really good family medicine.
That's such an amazing thing to think about, Steve. Just to think about how healthcare will change, how we will have a different way to engage with our patients, and maybe also how we will have a different way of collaborate with other professionals to assist our patients. And as we're nearing the end of the videocast, which I thank you once again for all the support on building this module. Is there any other advice that you would like to share with our audience as they continue to manage patients with COVID-19 and its long-term effects?
I think three things. One, I said, don't be scared to investigate someone who has appropriate symptoms that might not fit in with COVID, because we don't want to miss other medical conditions going on. I think that's one useful thing. I think the second thing linked to telemedicine and video conferencing to see patients is don't be scared to ask them to come in afterwards. We are still allowed to see patients face to face. That's very important. The third thing you might have noticed during this discussion, I talked about a post-COVID recovery clinic rather than long COVID or post-COVID clinics. And the reason for that is the vast majority of people that I saw who had COVID, if they were helped and supported with physio, psychology, some medical support, have very good outcomes. And I think there's a danger of letting people say, if I've got long COVID, I'm going to have it for a long time. If I've got a post-COVID and I'm on a recovery program, the anticipation is I will get better. And that's certainly true of the vast majority of people that I've seen. So I think we need to keep this positive rather than letting any negativity get into it. And I think we need to proactively support people to get that help and constructive increasing amounts they're doing within limits that gets them back on their feet again.
Steve, thank you very much for all your support. This has been amazing. I would love to continue this for much longer. But we will end here just to not take much of the time of our students. So thanks again, and nice to have you here.
And lovely to work with you, Hugo.